I don't know where to look, but I think the camera's there. So welcome to those of you on Zoom. And we have a almost packed house here in Mission Hall, which is wonderful. Happy New Year to you all, particularly to our returning master's students. My name is Jeremy Alberga. I'm the acting director of the Center for Pandemic Preparedness and Response. And we are delighted to be hosting this month's Grand Rounds. And especially excited for our speaker today, who is Dr. Can I call you Billy? Not William. Billy. Dr. Billy Fischer, who's here with us from UNC, Chapel Hill. And just give you a very brief overview. So I'll give you a brief overview of Dr. Fischer. He's going to come up and speak for about 30 minutes. And then myself and one of the students, Shakiba, will be moderating some Q&A. So Billy Fischer is a pulmonary and critical care physician and director of the Emerging Pathogens at UNC School of Medicine with an expertise in severe emerging viral infections. He graduated from UNC School of Medicine and completed residency in internal medicine and a fellowship in pulmonary and critical care medicine at the Johns Hopkins Hospital, where he was assistant chief of service. I'm going to stop there. And I think we can post his longer bio in the chat. And for those of you who want to look online. So without further ado, we are a couple of minutes behind time already. Billy, wonderful to have you. Welcome. And the floor is yours.
Great. Thank you so much for the introduction. Okay. Can you guys hear me okay? Yeah. So I am a bit of a walker. So if I stray and you can't hear me, just redirect me back to the center, but I tend to walk. Jeremy, thank you so much for that introduction. And really, it's a wonderful honor to be here with you all today. First, also, let me just thank Celeste. I think she's here. Celeste, thank you. Without you, I would definitely not have found every place that I needed to be. And Dan really has been an amazing host throughout this whole operation. Robert and Stephanie are the only reason that my slides actually work. So it's really exciting to be here. So if you read my bio, there's a lot of words, but at the end of the day, really what I am, I'm a critical care physician. I'm a bedside physician, and I got pulled into clinical research really for the need to try to understand how do we improve care for patients with some of the world's worst diseases, severe viral infections. And so what I thought I'd do today is really tell the story of how care for patients with Ebola virus disease has been advanced over the past 10 years and try to pull a couple of lessons learned about how we can respond better to other emerging infectious threats. And I'm going to start with a story. This is a story of a 9-year-old little boy that I met in the forest region of Guinea during early 2014. And the story of Thomas was that he had become infected with Ebola virus from his mother. And his mother had become infected during the preparation of a body for burial. Now, as is custom in many cultures around the world, the way that we show signs of respect and love for somebody that's recently passed is we wash the body in preparation for burial. Now, the problem with Ebola, and there are a lot of problems with Ebola, but one of the problems with Ebola is that the highest levels of viral replication that we see are in dead bodies. Viral replication increases from symptom onset until they pass away. And the other problem with Ebola virus disease is that the virus can literally get into every single body fluid. It can get into blood. It can be found in some people in some respiratory secretions. It can be found in urine. It can be found in vomit and diarrhea. It can be found in semen and cervical vaginal fluid. It can be found in the fluid within our eyes, as well as the fluid that bathes our brain. And it highlights the disseminated nature of this severe viral infection. And those two things together, really high levels of virus and its ability to disseminate throughout the body, really can transform this act of tradition, right, the preparation of a body for burial, into an act of transmission. And this is how Thomas's mother became infected. And when she became symptomatic, she passed the virus on to Thomas. Now, when their community recognized the signs and symptoms of Ebola, they quickly isolated them in an effort to try to prevent ongoing transmission. The Doctors Without Borders team that had built a treatment unit in Gueckedou, the forest region, heard about them, sent a team out to assess them. And when they met the case definition for suspect case definition for Ebola, they quickly transported them to the treatment unit that looks much like this one of these white opaque tents. And I was part of the team that was to receive Thomas and his mother to perform the initial clinical evaluation and start treatment. And I remember Thomas was critically ill. He was covered in vomit and diarrhea. He had a frozen left elbow and he wasn't able to move his knee because of severe pain. His pulse was rapid, and his blood pressure, it was so thin, the pulse was so faint that I wasn't able to actually even measure a blood pressure on him through the 2 layers of gloves that we had. And we actually went ahead and tried to provide really aggressive care for what was available at that time. Placed an IV, took some blood and sent it to the lab to try to see if he had Ebola virus disease or try to look for other infections. We started volume resuscitation. We gave him fluids, and with that, his heart rate came down and his blood pressure became detectable. We started empiric antibiotics because this could have been septic shock from a bacterial infection because he was a suspect case. He wasn't confirmed yet. And we started antimalarials because malaria is still the number 1, 2, and 3 cause of severe febrile illness in this region. But after about 2 hours, the temperature inside our suits raised to over 115 degrees, and the sweat had started to occlude and impair our ability to see. It saturated our masks, and we weren't able to I was having difficulty getting air back and forth, and we had to leave this critically ill little boy. The morning when I returned, his name was no longer on the suspect list, and the lab had said that when the test came in, he had tested positive for both Ebola and malaria. And when the team went in to move him to the confirmed ward, he had died. Now, I tell the story for a couple of reasons. Number one, in many ways, I think this encapsulates the classical response paradigm to Ebola virus disease over the first 40 years that we've known about the virus. And that paradigm has really been to identify the infected patient, isolate that infected patient, and then track all known contacts of that infected patient so that when they become symptomatic, we can isolate them. And this is really based on the idea that patients with acute Ebola virus disease, and the emphasis on it is on acute here, are only infectious when they become symptomatic. And so this identify, isolate, and track paradigm has actually been really effective at limiting the size of these outbreaks and really stopping outbreaks through stopping transmission. But the separation of patients and providers, it comes at a cost. It can sustain high rates of mortality, which we've seen with Ebola virus disease. It can impair learning, which we've also seen with Ebola virus disease. And the separation of that patient from the community also fuels mistrust, which we've also seen with Ebola virus disease. And I would argue that we've seen all 3 of those things in our responses to other emerging infectious pathogens, where isolation has been the center of our response. And so I try to remember this, and I try to think about this, because with every new outbreak, because isolation, I try to remind myself that isolation can be an incredibly effective tool at limiting transmission, but it's got to be coupled with aggressive supportive care so we can drive down mortality. It has got to be done in the setting with implementation of clinical research so that we can continue to improve that care and learn more about the natural history so that we can actually prevent transmission. And we have to do it in concert and in close collaboration with the community, so that we build rather than break down that trust. Now, 2014 was a turning point in many facets. With over 28,000 infections, this was way more infections than we had ever seen before. The prior largest outbreak was about 450 people. So we had many more infections, we had many more providers at the bedside, and we had increased opportunities to really get a better look at this natural history of Ebola virus disease and start to develop strategies for clinical care. We learned a lot from just observational data alone. We learned that in the first 3 days, patients present with really nonspecific symptoms: fever, myalgias, muscle aches, and anorexia, and that many of them will progress to a pretty intense gastrointestinal phase with significant volume loss, both from vomiting and diarrhea, in some cases losing 10 liters of diarrhea in a day. And if they get better, they tend to get better slowly over the next week, but a significant proportion of them continue to experience complications of Ebola virus disease long after they've cleared the virus from their blood, much like what we see with long COVID. If they don't get better, they progress into multi-organ dysfunction and die. We've also learned pretty consistently from this observational data that there's 3 independent risk factors that are associated with mortality: organ failure, and in particular acute renal failure, viral load. Higher viral loads are associated with increased risk of death, and age. What's a little bit unusual about the age is that the age at which we see increased mortality is much younger than what we're used to. With flu and other respiratory viruses, it's typically above 64, typically. But with Ebola, it's really above the age of 45 that we see an increased risk of mortality. Now, I'm going to talk about organ failure and volume and viral load and really highlight some of the data that supports their roles as being independent risk factors for mortality and some strategies that we developed in the field to try to circumvent these risk factors. I'm not going to talk about age, because age is interesting. We haven't figured out how to fix age, right? But what's interesting is that if you look at the treatment data, if we control the viral load, age drops out as an independent risk factor for mortality. All right, so let's talk about acute renal failure. And I am not a nephrologist, but I'm really excited about acute renal failure. So this is your kidneys not working, okay? So acute renal failure is extraordinarily common in acute Ebola virus disease. About 50 to 66% of patients that present to a treatment unit have evidence of acute renal failure. And this is data from a Carytown ETU in Sierra Leone that was run by the UK military. And you can see that acute renal failure, as defined by the rifle criteria, which I'm happy to go into later, is much more common in those that die as compared to those that survive. In fact, if you present with evidence of acute renal failure on admission, you have a 6-fold higher risk of death than if you don't. Now, the etiology of this renal failure is not clear. Many of us think it's the volume loss in that second phase of illness that drives decreased perfusion of the kidneys and results in failure. But actually, we were wrong when we looked. Well, we're partly wrong. We're always partly wrong. When we looked at the data, about 29%, about a third of patients who presented with phase 1, even before that volume loss, had evidence of acute renal failure, suggesting an alternative etiology, perhaps sepsis physiology, or maybe even the breakdown of muscle, something called rhabdomyolysis. But not only did we have to deal with the organ dysfunction, we had to deal with the complications of organ dysfunction, which were incredibly common, particularly abnormalities in potassium, which we saw in about 30% of patients. The problem was 50%, it was really high, 50%, it was really low. So we had to create or think about having infrastructure in place to give us daily labs to guide our treatment of patients. But what we found is, but if you think about it, if you step back, acute renal failure is something that we deal with every day in San Francisco and every day in Chapel Hill. These are complications that we know how to deal with if we provide the right kind of care. And if you look at the 27 people that were treated outside of West Africa, these were people that were treated in the US and Europe, they received a much different bundle of aggressive supportive care, and as a result, their mortality rate was markedly lower. They had markedly increased healthcare to provider ratios on the order of about 100 to 1, highlighting the resource and staffing requirements to provide care to somebody in an isolation setting. 100% of them received IV access in compared to a minority of people that received IVs in West Africa. And 70% required oxygen. And that likely reflects not a new phenotype to the disease, but rather more aggressive volume resuscitation that was able to be achieved with better staffing ratios and more aggressive care in the US and Europe. 30% received vasopressors, which are medications that artificially elevate the blood pressure, and 19% required hemodialysis or renal replacement therapy. And with that, the case fatality ratio was markedly lower at 18.5% as compared to the 63%, highlighting that these are complications that we know how to deal with, and if we provide the right foundation of supportive care, we can reduce the mortality. Now, 85% of these individuals also received access to at least one investigational agent, but only a minority actually completed their case, if you look in the red box, and many of them experienced adverse reactions. Now, if you look at those therapeutics, we don't think that they played a role because none of them were associated with an improved mortality in clinical trials, and none actually showed a really robust antiviral effect in clinical trials during the outbreak. So this really highlights the role of aggressive supportive care in really managing the complications of this viral infection. So in an attempt, and I think it's also really important that we recognize that there is a gross inequity in access to good supportive care between those that received it in West Africa and those that received it outside of Africa. And so in an attempt to try to achieve a single standard of care, WHO really led a comprehensive effort to write optimized supportive care guidelines. This was led by Janet Diaz, who is a UCSF alum. She was on faculty here. She is an amazing, amazing leader at WHO that's really been driving a lot of this work forward. But none of this is rocket science. It's increase your provider to patient ratios to not only be able to assess the patient, but also reassess the patient, provide volume resuscitation to account for GI losses and septic shock physiology, be able not only to diagnose the problems, but be able to manage them with close monitoring of electrolyte abnormalities, symptomatic management, and then the use of prophylactic antibiotics and malarial medications to potentially treat any co-infections. But the implementation of these optimized supportive care guidelines are extraordinarily difficult in the traditional setting. This is what a traditional Ebola treatment unit looks like in the bottom left. It's a tent city. And you have to wear this really restrictive personal protective equipment, which is in the top right-hand corner. This is me and Cameron Mode, who is one of the best clinicians I've ever worked with in Guinea. And you can see, though, that personal protective equipment, where temperatures get to over 115 degrees, it limits the amount of time you can spend inside. On average, we were only able to spend about 45 minutes unless you were pushing the limit. And that's 45 minutes for every patient that had to be seen, not one patient. Now, the opaque walls really prevent continuous observation, which you need in order to deliver this aggressive supportive care, like vasopressors, oxygen therapy, as well as to operationalize investigational agents that require close monitoring for adverse events in the setting of clinical trials. It also increases the resistance of patients and families. So actually, people didn't want to come, not surprising. Right? When your mortality rates were 60 to 70% and you couldn't see what was happening inside, many people didn't want to come inside. And that resistance delayed the time from symptom onset to presentation, which we're going to see is a major factor in the efficacy of our therapeutics. And so we had to change the paradigm. In addition to some of the therapeutics I'm going to talk about and the vaccine, which I'm not going to spend a lot of time about, I think one of the most important innovations in response to Ebola was really changing how we approached it and embracing what we called the 4S model. Now, I changed the number of S's that I have, and I changed the wording of what the S's mean, but really it's rethinking care delivery in a complicated space. And one of the things that really revolutionized this was this cube. Now, it's exactly what it sounds like. It is a 6-sided plastic tent. And there's many variations of this, but it does something really important. It brings us closer together. It brings providers and patients together. And I want to highlight 3 different care providers here. There's the person in yellow. This is the traditional PPE. He or she still has about 45 minutes in that space before they have to get out, but they can provide direct patient care. We can limit the number of providers in that space, though, because now we have the ability to observe them continuously. And if they get into trouble, we can help them out. We've got this gentleman in green scrubs and blue boots who's on the opposite end of the spectrum. He's in no PPE, but he has the ability to directly see this patient with Ebola virus disease. He can continuously monitor that patient, identify when we have to respond emergently. He can also deliver therapies. He's actually delivering right now investigational agent through tubing on the outside, but he can modify the flow of that therapeutic without wearing personal protective equipment. But if he has to go in urgently, he'd still have to put on that personal protective equipment and go in through a double door entry. Except there's a third person. And this person's in between the person in PPE and the person in green. I don't know if this works, if you can see my arrow, but it's a person here. Now, all these tent structures have the ability to basically step into the cube and still be completely covered in plastic. And so some people call it huggy suits. Other people call it this invagination system, where you can literally step in and be able to directly intervene on the patient without wearing full personal protective equipment. I've done physical exams, I've placed IVs, and done point of care ultrasound, all while wearing these suits. The other thing, though, is that we can do this all together. So we can round on this patient and discuss their care as a team, as opposed to only one patient seeing a patient, or one provider seeing a patient in a 6-hour period. So it changes the way that we learn, and it improves information flow from the treatment space into the care space. This really provided the foundation for aggressive supportive care, on top of which we were able to add investigational interventions, and was really critical to the role of to the implementation of therapeutics. So, all right, let's move on now and talk about viral load as a risk factor for mortality. This is data out of Sierra Leone. It's from the NGO called Emergency that was in Gueckedou. And what they did is they followed 84 patients with Ebola virus disease and collected samples serially to try to understand Ebola viral replication kinetic differences between those that survived and those that died. On our y-axis, we have viral load, log copies per mil. X-axis is time from symptom onset. 38 survivors are in blue, 46 non-survivors are in red. And what this data tells us is that there is a significant difference in the level of virus between those that survive and those that die. At 2 days from symptom onset, that difference is only about a log. But by day 5, 6, or 7, we start to see those curves differentiate, meaning that those that are able to survive are able to control their viral replication, and those that are not able to survive can't control their viral replication. By day 7, that difference is increased to a log and a half, and by day 13, it's increased to about 5 logs. So a significant difference in viral replication. If you survive, survival is really dependent on the ability to control the viral replication. Now, data from the same group said, well, we also see something else that's interesting, is that control of viral replication at least temporally correlates with the appearance of an Ebola-specific humoral immune response, or IgM or IgG response. So survivors are on the left, fatal cases are on the right, viral loads, top row, Ebola-specific IgM is in the middle, Ebola-specific IgG is on the bottom. And what you can see is right around that day 5, day 6, day 7, you start to see control of viral replication, just like we saw on the prior slide. But now we see that it corresponds to the appearance of an IgM response in survivors, whereas we don't see it, one in fatal infections, and a really nice Ebola-specific IgG response in survivors, whereas we don't see it in fatal infections. And this data, combined with non-human primate data, really ushered in the era and supported the development of monoclonal antibody therapies. I don't want you to remember anything from this slide other than there were lots of groups working on the development of new therapies. And they developed different groups developed three monoclonal antibodies. ZMapp, which was a chimera between mouse and human antibodies. Regeneron, which was another cocktail of antibodies. And MAB114, which was isolated from a survivor in the Gueckedou outbreak in '95. And these were able to be turned into therapeutic treatments. Therapeutic treatments may be redundant, so maybe just treatments, and showed almost 100% survival in non-human primate models if used early. Now, similarly, antivirals were also direct-acting antivirals were being evaluated. Now, this was Remdesivir was the first. This is it's a nucleoside analog, so it looks like a building block of RNA. It gets incorporated into the virus as it's replicating, but it's a chain terminator, so it stops the ability to add nucleosides. In these days, this was not called Remdesivir. It was a combination of letters and numbers, GS5734. And actually, much of our safety data about Remdesivir came from its use in Ebola. The first one to be evaluated was ZMapp, and the trial got started at the tail end of the 2014 epidemic. This is really important. We had this outbreak for 2 years, and a randomized control trial was only able to be started at the tail end. 71 patients were randomized, 35 to standard of care alone in red, and 36 to standard of care plus ZMapp. And you can see that they were not able to complete enrollment. They only got 71 out of an intended 100 people because the outbreak ended. But there was a trend towards increased survival among those that received standard of care plus ZMapp on the order of about 78%, as compared to 63% in the standard of care group alone. And Bayesian analysis demonstrated that the posterior probability that ZMapp was better than standard of care alone was about 91%, which was lower than the a priori threshold of 97.5% that was for this trial. So on the one hand, really amazing job. NIH deserves a ton of credit for operationalizing a really important randomized control trial, it was open label, in the setting of an outbreak, which is a difficult thing to do in those tents. On the other hand, we got it started so late, right? It had to go through all the regulatory approvals and protocol design that we actually weren't able to reach enrollment. And so now what do we do with this? What does this data tell us? Some of us argue that's a pretty strong evidence for an improved survival, whereas others said it's not definitive proof. Once again, navigating uncertainty. And we didn't have a lot of time to figure it out because there was a new outbreak in the North Kivu region in 2018. This is the eastern part of the Democratic Republic of Congo, active conflict zone for decades, incredible movements of populations due to refugees, complicating an already complicated situation of an Ebola outbreak. In an attempt to try to equalize this inequity in access to supportive care and therapeutics, WHO and the National Biomedical Research Institute, I'm going to call it by its French acronym, the INRB that was led by Jean-Jacques Muyembe, who's in the top right, decided that that in order to operationalize the access to optimized supportive care and therapeutics, they were going to launch a program called the Monitored Emergency Use of Unregistered Investigational Interventions, MURI for short. And my role was to try to operationalize this in a conflict zone in an Ebola outbreak. And really what this program called for is that it allowed for the use of unregistered interventions if a clinical trial could not yet be started in the setting of a public health emergency when the preclinical data supported the benefits over the risks with informed consent. And what was really important about MURI, and the reason that I included here, we treated over 700 patients with one of these 4 different therapeutics. but it really paved the way to understanding how to operationalize a clinical trial in an emergency setting. This is essentially an expanded access program. But as soon as the RCT could be started, we stopped the MURI program. Because the RCT really represents, and Jeremy and I were talking about this, the way to expose the fewest number of people to the least effective strategy. It takes me weeks to get that out and to also understand what it means. But it essentially is the best way to figure out what works and what doesn't. And the expanded access programs are great for figuring out how to operationalize it. But we really have to move to that RCT. And so the NIH and the INRB led this program, this randomized control trial called Pamoja Tulindi Maisha, which is Swahili for Together Saves Lives. And there was a lot of consultations about whether a placebo should be used. This is extraordinarily complicated. When you have a mortality rate of 65%, do you use a placebo, or do you have enough data from that PREVAIL II study to suggest maybe we should use ZMapp? This was really guided by the country that was affected, that a placebo wouldn't be accepted. And so ZMapp became the control arm of this study in comparison to Remdesivir, MAB114, Regeneron, EB3, on the backbone of optimized supportive care. And the primary outcome was a 28-day mortality. And this trial really transformed Ebola, because for the very first time in the history of this virus, we found 2 interventions that could reduce your chances of dying. Overall, no difference between ZMapp and Remdesivir, mortality about 50%, significant reduction in mortality in MAB114, Regeneron, EB3, but the details matter. If you had low viral load, meaning a CT value of greater than 22, and we'll talk about what that means, we could get your mortality down to 10%. But if you had a high viral load, of which 40% of the population had what we called a high viral load, a CT value of less than 22, your mortality was still 64 to 70%, but it was significantly lower than the 84, 85% that we were seeing with these other 2 interventions. So incredible progress, but still a ton of room to go and how to improve it. And I want to take a look at this for a second. So look at the first column. This is time from symptom onset to randomization. The second column is the 28-day mortality. The third column is CT values. And the fourth column is creatinine, which is a reflection of acute renal failure. How many people feel really comfortable with CT values? All right, this is scientists' attempt to confuse us. All right, but we're going to push back a little bit. So CT values stands for cycle threshold. It's really a PCR output. So remember, PCR does all these like cycles of amplification of RNA. So if you have a high CT value, it means you have little virus. And if you have a low CT, it means you have a lot of virus. So think of it this way. If we have a little bit of virus, man, that PCR machine has to go through many more cycles before it amplifies that RNA beyond the threshold. So that's why your CT value is elevated. And if you have a ton of virus, you only have to go through a couple cycles before you get detection, okay? And so what this data tells us is that for every day from symptom onset to treatment, there's an 11% increase in mortality. But look closely. Every day up to day 5, your CT value drops. That means that your viral load is increasing. It's the same thing that we saw with that viral replication kinetic data. So for every day that viral load increases and your mortality goes up, okay? And so that means that we have a really narrow threshold in which to intervene with these therapeutics to be able to improve mortality. That CT value of 22, day 5. You know what the mean time from symptom onset to presentation? 5.5 days, meaning meaning half of the people were presenting after 5.5 days, after which we've peaked our viral replication. So we've got a narrow therapeutic window, which means that you can have the greatest intervention in the world, but if you can't get people to come in, it's not going to work. And this is really where trust and community engagement is critical. We might be able to modify this window a little bit. So this is a complicated figure that I love. So percent survival, this is non-human primate data looking at non-human primates infected with a different strain of Ebola Sudan. That black line straight down is the single control animal that got infected but not treated, died at day 6. The dotted line is 90% of control animals historically that got infected died between days 8 and 10. And that if we give them a monoclonal antibody 5 days after infection, 100% survival. That's awesome. If we wait until day 6, that survival drops to 20%, okay? The numbers are a little bit different because it reflects a mutation and changes in the FC effector function. The same is true for Remdesivir. If we give it 4 days after infection, 100% survival. If we wait till day 6, 20% survival. If we give them together, we can improve our survival to 80%, suggesting that maybe that therapeutic window is modifiable through combination therapy. And this makes sense. Those antibodies tend to stay in the circulation. They're not able to necessarily get into cells. But this direct-acting antiviral Remdesivir, it's a nucleoside analog, it slips into cells pretty easily. And so together they can reduce that viral replication and improve chance for survival. Now, we need these direct-acting antivirals for another reason. We see, remember in the beginning we talked about how the Ebola virus can get into literally every body fluid that we produce? Yeah, well, this is really unfortunate. So this is data from our group in Liberia that looked at the persistence of Ebola viral RNA in semen. Okay, 346 Ebola survivors are followed in our cohort for the past 8 years. 149 men donated semen, a mean 681 to 786 days from their symptom onset. So we're looking really about 1 year to 2 years out from their symptom onset. We detected Ebola viral RNA in 9% of these gentlemen. In 11 of the 137 that donated more than 2 years after their infection, we detected in about 8%. So just think about that for a second. This is like a negative RNA virus. This is like getting flu, but then having it in your semen more than 2 years after. And this really represents, I think, another paradigm shift in how we think about the reservoir of Ebola. We don't really know what it is. We think it may be bats, but I also think there may be a role for humans to play as a reservoir in this disease. And you can imagine the stigma that can be associated with that potential for persistence. The longest duration was 965 days in our cohort. I mean, that's an incredibly long time. And it's actually, the persistence of Ebola viral RNA has been associated with at least 10 clusters of outbreaks through suspected sexual transmission. This is one of them. 2021, outbreak in Guinea, 18 cases, 9 deaths. 2 of those genomes were sequenced, and they were compared to representative genomes from all prior outbreaks, and they were able to infer a phylogenetic tree. Those 2 genomes from 2021 were most closely linked to 2014. When they compared them to 1,063 different genomes from 2014, something really interesting was found, that they shared 10 key substitutions that developed during the 2014 epidemic, telling us that this was not due to a new crossover event, which wouldn't share those substitutions, but that this was somehow linked to the viruses from that time period. Now, they most closely clustered with 5 genomes in the same region of Guinea that was collected in 2014, but they differed by 12 substitutions. And based on the evolutionary rate, this is much lower than what we would expect if there had just been continued transmission in this region that was being undetected. And the slow evolutionary rate is actually a hallmark of viral persistence in immune privileged sites within human hosts, linking again to viral persistence in semen with the potential for the ability to cause new outbreaks. And so we have to figure out a way to not just eradicate the virus from the blood, but also to clear it from other compartments in the body as well. And so this really led to a study of Remdesivir, because it's the only one that can probably get into that compartment. And based on non-human primate data, we see nice penetration into the testes to evaluate its ability to eradicate virus in semen. 18 adult male survivors, 18 years of age or older, who had at least one of 2 semen samples PCR positive within 40 days of enrollment were randomized to either 5 days of Remdesivir or a placebo. This is the very first infusion here. This is years before COVID hits. So this is some of the first times that this therapeutic was used. This was led by Libby Higgs and Dr. DeConte and myself. And the key endpoint, or the key primary endpoint, was the proportion of samples that are negative. So 6 semen samples were collected within the first 28 days, and that was period 1. Part 2 was 4 semen samples were collected, and the primary endpoint was the proportion of samples that tested negative. In the first phase, that was designed to evaluate for an antiviral effect, we saw a trend towards an increase in mean assay negativity rate of 85% among those that received Remdesivir, and compared to 76% that received placebo. But it didn't reach statistical significance. But in that follow-up period, in that 2 to 6 month period, we did see a significant proportion of men were able to clear the virus in their semen who received remdesivir as compared to placebo, highlighting, I think, an important role for a direct-acting antiviral, and really, I think, ushering us into the next phase of antivirals, thinking about combination therapy, both to get rid of the virus with monoclonal antibodies in the blood, but then also to combine it with antivirals to extend that therapeutic window and potentially eradicate it from other sources. All right. I've got a few seconds left, and I feel Jeremy looking at me. So I'm going to go quick. But I want to show you some really exciting data. So, all right, let's think about this. It's not enough to do a good job. It's not enough to learn. We then have to figure out how do we learn better and how do we do this better. So a couple things that I want you to think about. This is, when I think about the past 10 years of Ebola, I think of a couple things. Number one is we have got to shift away from crisis response, where we fly in and we get started once an outbreak has been declared. We're too late, right? PREVAIL II, amazing study, incredible people did this work, but it was at the tail end of a 2-year-long epidemic. We've got to be ready before. Dan and I talk about how do we create a warm base right now that is able to integrate with the community and gain that trust before that emergency happens. And it's a good reminder that outbreaks begin and end in communities. Right, we've got the best therapeutic in the world, but it doesn't work if you can't use it in the time frame that it needs. So you have to build that trust now. So that outbreak response or that warm base, it has to be patient-centric so that people want to come, but it's also got to be accessible to accessible by the community, and that we have to prioritize clinical research. And I think there's a way to do this. So, and I'm going to argue very quickly that Lassa fever may be an even greater threat to global public health security. Unlike Ebola, which causes sporadic outbreaks, probably due to poor surveillance efforts and not a clear understanding of its natural reservoir, Lassa virus causes a persistent and predictable threat in and across West Africa. It's found in the Maximus rodent, the most common rodent in sub-Saharan Africa, and results in 500,000 infections and 5,000 deaths every year. This is based on outdated epidemiology from 1987. So if you guys are interested in epidemiology, we could use your help here. All right. And so we have to better understand, this is again due to an absence of diagnostics and rigorous surveillance. But if you think about it for a second, in 1 year, we see more infections with Lassa than we ever do with Ebola in the history of Ebola. And in 3 to 4 years, we see more deaths from Lassa than we do from all Ebola outbreaks combined. And many of these deaths can be prevented with better diagnostics and better access to supportive care and novel therapeutics. Really amazing data from Christian Happy and Redeemer University highlighting that these outbreaks happen every single year in the dry season. And this is because as the vegetation goes down in the fields, they lose that protection, they lose that food source. And so they move into people's homes and increase interactions between people and pathogens. All right, so what did we do? We built a diagnostic lab because there was no diagnostic labs available in this area in Liberia. They were sending samples to Sierra Leone and weeks later they would come back, maybe. So we built a diagnostic lab and we made it accessible to the community. In addition to our research efforts, the test is free. If you have a clinical suspicion, you can send the test to us, we'll run it right away. And you get your results back the same day or the next morning. We've also put the same machines and diagnostic platforms in the National Public Health Institute of Liberia and are collaborating closely with them so that we're building the national capacity for surveillance. We've also invested heavily in the treatment space. How do we make this? Nobody wants to go here. Nobody wants to go to an ICU or an isolation unit. But how do we make this more comfortable and more effective for the providers and the patients? And so we've started to think about we've invested in the space, put in electricity and running water and sanitation. We've created a family area, so now the patients can actually interact directly with their families, and their families can see what's going on. Our psychosocial team can support them in that space. We've engaged heavily with the community, and in fact, it is a community-owned project. The people that do the surveillance in the communities are people that are elected by their community to perform health surveillance. We've tripled the size of that program. And now, in addition to their health surveillance activities, they also help identify people that might make the case definition for Lassa fever. So close community engagement. And that allows us, and this is my last slide, that allows us to have a closer observation of this natural history of Lassa fever to better understand the prevalence, the incidence of Lassa fever among febrile admitted patients in our PREPARE study, collect samples during hospitalization and for the year after they are discharged to better understand. So this is some primary data that is literally hot out of my email, but I want to show you kind of the results of this community-owned clinical research program. Already with 52 infections over the past year and a half, we see a difference in viral replication kinetics. These are survivors on the left versus fatal infections on the right. The blue is the GPC target, and the red is the L target. But you can see that survivors control their viral replication much better than fatal cases, okay? And now the dogma is that the immune response that's responsible for this is a T-cell response. And I agree. I think the T-cell data looks great. I agree that it's playing a role. But the thought process is that humoral immunity, or antibodies, don't develop until long after convalescence. But our data is actually doesn't show us that. Our data shows something entirely different. So this is IgM and IgG responses, and the red is IgG. So sorry, I forgot my my label here. And the blue is IgM. But what you can see, and our y-axis is the proportion of participants that are antibody positive. X-axis is days post-symptom onset. Already, you can see that there's actually a pretty nice humoral immune response among survivors, but there is zero IgG response among those that survive, highlighting that maybe the humoral immune response is more important than we had originally anticipated. And this is important because now monoclonal antibodies have become available that might be effective at reducing mortality, certainly in non-human primates. Lastly, this is a project that is following 5,000 people in 3 rural communities of Liberia to better understand the seroprevalence. And like other studies, we see high rates of seropositivity, but it also gives us the opportunity to understand the sero changes, the variability in serologic dynamics. This is led by, there are no words to describe how amazing Catherine Nimley is. She is down here, but she is the star. She's going to be the next great clinical researcher out of Liberia. I'm going to end with this slide. I promise, Jeremy. Outbreak response have to be patient-centric. They have to be, isolation's great as an effective tool at limiting transmission, but we have to couple it with really good supportive care and pathogen-specific therapies. We see that there's good data that the combination of supportive care and monoclonal antibodies can be effective at reducing Ebola mortality. And I'm going to argue that I think it can work for other infectious diseases. We can generate those monoclonal antibody therapies right now. But the community engagement is critical because patients have to present early in order to make a difference. And in outbreaks, it's not just what we know that matters. It's really about what we can learn. And this is where you guys come in. This is where you guys can lead to answer the next generation of questions, to better understand the rules of these pathogens, the risk factors for disease progression, and the therapeutic windows in which these interventions can be effective. I will stop there, but I'm so excited to be here with you guys today, and really it's been an honor to meet everyone, but also just get energized by the ideas that are here. So I'm happy to take any questions, and I'm 29 minutes.
Have a seat, please, Dr. Fischer. Fantastic talk. We have about 40, I think we have 8 or 9 minutes. We have about 40 or 50 students in the room and maybe a few online, and talk about an amazing amalgam of global health sciences. And I wanted to write this down just watching your presentation. You hit on epidemiology, community engagement, statistics, clinical care, field operations, experimental medicine, ecology, and you even did a little bit of hospital design. So congratulations, what an amazing talk. Thank you again. I want to welcome up one of our master's students, Shakiba Gassemi Asal is here with us. Please have a seat. And she's co-hosting with me, and we'll ask you maybe the first question. Welcome, Shakiba. Shakiba is a physician who graduated in 2021 from an Iranian medical school, and she started practicing in emergency care in a remote area in Iran. And she's interested in infectious disease prevention strategies and health system preparedness. So Shakiba, the first question is yours, and then we will open it up to those of you in the room. And I suppose, Stephanie, maybe let me know if there are any questions online.
Thank you so much. So my first question is that when I was working as a physician during the pandemic, many of those recommendations that when I was started working as a physician, the pandemic started. And then I started to read about previous pandemics occurred in the world, and which what was surprising for me was that many of the mistakes occurred before was happening step by step in the pandemic again, at least in my country. So what is my question is that what are the 2 or 3 key lessons that we are learning from, for example, Ebola virus that you mentioned for future pandemics? I know that you already mentioned some of the key points, but my actual question is that not in an optimistic way. For example, when I was working, recommending isolation for patients was not a good idea because people had to go to work and otherwise they didn't have money, they can't afford isolation. Or for example, students couldn't have online education in terms of isolation again because it was not fair because many students didn't have access to internet connection and it was not a good idea again. So this is my question.
That's a great question. I always hate to hear my voice loud, but really important question. And I agree 100%. We make many of the same mistakes over and over again. And I think part of it, though, is there's a huge fear component whenever there's a new pandemic. And I actually I want to take a second to really acknowledge what you said, is that not everybody could isolate because they had to work. And not everybody could do online education because they didn't have the right resources. And I think that really reflects the gross inequity in access to everything, right? Education, support. In Korea, what they did is they encouraged isolation, but they supported households with food and things. Really difficult to do, but really admirable efforts there. COVID did not expose inequities in access to care. They've always existed, right? I mean, this is our whole life is about inequities in access to care. And I think, though, it really reminded a lot of people about this. So a couple of things. Number one is we can't shut down our borders, and we can't shut down other borders, and we can't say that hopefully we've all recognized that doesn't work. Not only does it not work, but it condemns the country that who we're saying are not allowed to come to us. And these are global problems, and these borders are artificial borders that we've created. And so I really think that global health problems require global health solutions, or emerging infectious disease problems require global health solutions. So number one is I think we have to really be careful about isolation. It is a tool to be used along with many other tools, and it can't be used alone. Number two is that we have to get better at communication, communication of uncertainty. I guarantee you we won't know what to do the next time a pathogen hits. I guarantee it. I guarantee we won't know exactly how it's transmitted. We'll screw it up. So we have to do a better job at communicating on uncertainty. And I can tell you like as a physician, I was trained on literally how not to communicate. And so I think we all need help. And I think it's interesting. So really interesting. We're setting up this treatment unit at UNC for special pathogens. And I've got, and I think it's really interesting. But one of the things that we're doing is we are funding a community-based organization to understand who are our at-risk communities in the region that we're responsible for, and also who influences those communities. And the idea here is, can we learn how to create a bidirectional flow of information with marginalized and at-risk communities before the emergency happens, so that we can help convey, accurate, as best as possible public health information. So I think number two would be conveying of public health information. And then number three is I'm going to go back to my warm base idea. And the idea is that we know what countries and what areas are at the highest risk for spillover events. And by creating warm bases that are accessible by the community that implement clinical research, I think we can improve communication with communities before the emergency happens and be able to respond and also recover better. We're so focused on response that we fail to recover. And these countries that are affected are often left off decades behind in terms of their ability to respond to the next one. So we're creating more susceptibility to infectious diseases. That's a hard question, and I probably have 400 answers, but those are the three that are at the top of my mind.
Thanks, Billy. Great answer. I think we've got a couple of minutes, I think. Maybe we'll take a couple questions from the.
Okay, sure. I'll just go ahead because we have time constraint. It's okay. You want in your presentation.
We need it because of Zoom.
Oh, I'm sorry
you.
about it. Okay, I'll do that. So in your presentation, you will talk about increase potential survival rate for Ebola patient. One advanced kind of solution provided by the industry is coupled a very novel kind of therapeutic solutions, right? My question is like, because you talk about this dilemma of accessibility for the patient, especially they're out of the U.S. area. So my question is that for compassionate use kind of program provided by the corporate, is that one of solution that could help you with accessibility, or is there anything else can be more optimal listed?
By corporate, sorry. Are you asking if companies?
New drug or novel drug or solutions provided or developed by the corporations industry, pharmaceuticals?
So
they have this compassionate usage. Is that not good enough? Or?
Yeah, no, thank you so much for that question. I think it's really, really interesting. Gosh, so I think it can be helpful and harmful. All right. So number one is I really like this MURI framework, the monitored experimental emergency use of unregistered interventions. I told Jeremy I'm awful with acronyms. But I really like this framework. So what happens is that they get a panel of experts, or with expertise, I should be careful, to try to identify which therapeutics have safety data and efficacy data, which are the most promising. And so they almost prioritize these agents. And then there's a discussion about whether or not, what the availability of those therapeutics are. But we have to be really careful because the expanded access program, or the MURI program, it can't compete with the randomized control trial. If we just provide expanded access, we will never be able to really determine efficacy of that therapeutic, okay? And if we don't get licensure, we threaten the ability to get it to to populations beyond that country. So I think this is really important. So I think MURI was really helpful in terms of identifying how to operationalize therapeutics and providing access to promising therapeutics. But it was really an on-ramp for the randomized control trial, which determined which therapeutics were helpful, which ones were not, and then we can move forward there. But production is a really important piece. I think we also saw during the COVID pandemic that there were effective therapies, but they were not globally distributed. They were only used in specific countries. That's not helpful for a global pandemic. We can't allow it this virus to replicate in some countries and not in others, because will just feed into those countries that are therapeutic, or that have access to the therapies. So I think when this happens, I think a MURI framework is a really nice setting in order to figure out how to operationalize therapies until a randomized control trial gets started. That's really the best way to go forward to determine which ones are effective or not. But that there has to be global distribution and global access. And arguably, we should be doing the clinical trials globally. I mean, we're all, different populations, different environments, different presentations of illness, I think, require us to look at these therapeutics in different settings. Yeah.
That comes to regulation.
Yeah, I mean, yeah, that's a really important. The regulation's really, really difficult. And fortunately, I focus on the patients more than the regulatory pathways, but they're important.
Someone else's problem.
But we could do that now. We could do that now. I mean, we can design a clinical trial for Ebola. We could design it for Lassa. We could do it for Crimean Congo hemorrhagic fever. And we can go to the countries that are going to have those cases because we know where they occur. And we can say, hey, what do you guys think about this framework? And what do you think about if we prioritize the agents until an outbreak happens, so that now we've got an approved regulatory framework for a clinical trial, and we have a prioritized list of agents in order to try. We get MURI going until a randomized control trial can get started, and then we get across the line. There's not a lot of incentive to develop therapeutics for neglected tropical diseases, just from a market perspective. The FDA does have a voucher program for neglected tropical diseases that if you get a therapeutic to licensure, you can get a voucher. And that voucher allows you to take any drug in your system to market 6 months to a year faster. They are. But those vouchers are worth, hundreds of millions of dollars, or, I would argue billions of dollars with a brand new cholesterol drug or, a weight loss drug. It would change everything. So I think the FDA has been thoughtful about how do we develop incentives to bring some of these therapeutics to market. I think I answered a lot of questions.
Great. So I'm going to get in trouble with whoever's coming in next to teach. So please join me in thanking Dr. Fischer. Fabulous talk. And I think we have one question on Zoom. Stephanie, if you could put them in touch. I apologize for running out of time. Thanks, everyone. Have a good rest of your day.